Welcome to the panel discussion, session 2 on non-metastatic prostate cancer. And we have all our esteemed panelists with us. So these are the 7 articles, abstracts and articles which have just been presented, and we'll try to bring out the clinical implications of these abstracts in our day-to-day practice. So the first one was the 15-year outcomes of PROTECT trial, which showed that there was a 2 times increased risk of metastasis, long-term ADT, and local progression in the active monitoring group. So the of the 2 major shortcomings of this trial, the first major shortcoming was that it ended up including intermediate as well as high-risk patients. So my question to Dr. Jagdeesh, sir, is, sir, what patients are best suited for active surveillance, in your opinion? Absolutely low risk. Please take the mic. Thank you, sir.
No question, low risk. Very low risk.
Okay.
Now, intermediate risk can be thought of in very second.
Okay. So intermediate risk with GG2, possibly, but low and very low risk. Okay. So let us see what the data is saying. Now, there are 2 major consensus studies are available. One is a detective study that, as well as the November International Consensus Meeting, they both and the guidelines suggest that any patient with more than 10 years of life expectancy with low risk or favorable intermediate risk should be offered active surveillance. Any patient who has Gleason 3+4 can be included only if other favorable characteristics are present. That is, the PSA should be less than 10. The stage should be less than T2A, and the biopsy characteristics should be low core positivity. Gleason 4+3 should not be included into active surveillance, and T2C or more should not be into active surveillance. So there was one more thing that was pointed out in the detective study, that the low-risk disease should be excluded if the extent or stage of the disease based on the multiparametric MRI. Would you agree with that?
Actually, multiparametric MRI is not going beyond the prostate.
Okay.
So the
Okay. But all of them agreed that if the multiparametric.
3 cases.
Okay. Okay. Answer in your. It should be included. Okay. And sir. Staging. 30% upstaging is there. There's a problem in 3+4. And sir, what are the most important things that will base your decision? Well, there are a lot of things: Gleason grade, PSA, T. One most important factor that you will base active surveillance on. That in follow-up. Okay. While including, I was asking. Okay. Okay, sir. So as per the November consensus, it was the Gleason grade group that is most important while including the patients. And the second shortcoming. That target biopsy. Mm-hmm. Okay. With the index lesion theory coming in. So. Okay. I was just coming to that, sir. I'm just coming to that. That's the second most important shortcoming was it was active monitoring. It was the less strict protocol. So discussing about the protocol for the sir, my question to Dr. Pankaj sir would be, prior to including the patient for an active surveillance, would you advise for an MRI? Definitely, maybe not. Which 100%. If the patient comes to you with a biopsy report and MRI has not been done, would you ask him to get it done now?
Yes, sir.
You will. So the second question would be having a targeted biopsy, which one preferably? A combination of both. If not, if you will not refer, you will not advise targeted alone. Why would be that, sir?
So, one of the reasons is that there is still some amount of variability.
Sir, the combination actually. Sir. And if the patient does not have a combination, did not have a targeted biopsy and MRI prior, would you advise him a confirmatory biopsy? So if the patient comes to you with a biopsy, has a biopsy but not a targeted biopsy, so would you advise him a maybe? Okay. So because a couple of years ago, the confirmatory biopsy was mandatory at 6 months to 1 year given. Okay.
My philosophy is as we are going so
Yes, sir. 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 Definitely, sir. So regarding the follow-up on active surveillance, so my question to Dr. Rajiv Yadav, sir. So first question is, how regularly would you advise regular MRIs? And if yes, how regularly?
So in my mind, MRI
Main.
so the first time I did an MRI
1 year. Okay.
but it is one mind.
2 years. Okay. So do you recommend time-bound repeat biopsies in the patients on active surveillance?
So I am very convinced about and
Trying to change it. So what would and what are the triggers for a repeat biopsy and triggers for classification in your practice? So just summing up what Sir has said about these things, that every patient who undergoes an active surveillance needs an MP-MRI at some point of time. Prostate biopsy should be performed both with the MRI guided as well as systematic biopsy. And if the patient had an upfront multiparametric followed by a combination biopsies, there is no need for a confirmatory biopsies. Now these consensus meetings did not recommend routine timely surveillance biopsies. However, there is a caveat that the sensitivity of MRI in detecting progression is only 59% and specificity is only 75%. And the guidelines are recommending that a repeat biopsy should be offered to every patient every 2 to 3 years, because multiparametric MRI is not very sensitive and specific in picking up a progression in any of these patients.
Can I just make one point?
Sure.
The problem in my practice, I've been seeing this for the last 2 decades or so. The changing scenario of the patient's relatives and spouse, they are very PSA sensitive. In fact, patient's wife is more PSA sensitive than the patient. And therefore, it's always a trouble for us to how to convince them not to worry about this. And they go on getting into so-called Google universities. That's another issue, which we have to sometimes fall prey to that.
Just to add to that, the one of these consensus November meetings had a consensus that if the patient is anxious, we should not offer them surgery. We should offer them more consultation rather than surgery. So my question to Dr. Dharmender is the outcomes of active surveillance. So of the patients who we put on active.
Before that time, we didn't talk about trigger. More than 50% of PSA, if it goes up, it's worth doing biopsy. And if you have a DRE, especially on the contralateral rope, like if you have one on the right side and the one follow-ups, you have another heart nodular field on the follow-up DRE, it's again an indication for biopsy.
Sir. So Dr. Dharmender, of the patients that you put on active surveillance, how many remain on active surveillance about 10 years from now?
So patients who are actually offered active surveillance, I think the usual data was somewhere around 1/3 of the patients continue to be on the active surveillance even after 10 years or in a longer time frame. And almost 2/3 of the patients, they eventually need any radical treatment. So somewhere around that percentages.
Yeah. It's around 50 to 60% patients may need treatment about 10 to 15 years of being on active surveillance. So the next abstract discuss about the oncological and functional outcomes of unconventional histology. So, and they found out that the UH has poor oncological outcomes, the poorest one being intraductal carcinoma, followed by cribriform, ductal, Gleason grade 5 and Gleason grade 4. So, sir, Dr. Rajpal Singh, sir, how commonly do we see these unconventional histologies in our practice?
It is is less common, and mostly we don't see these.
We commonly don't see. So
actually, we see more neuroendocrine types.
More, sorry?
Neuroendocrine types.
More neuroendocrine, but that will be in the metastatic phase.
Even
the
local
primary presentation.
Yes.
But they suddenly have a drop of more, and I say that relatively speaking, of IDs. Suddenly, either of the copies are
that could be the reason.
Suddenly, out of the blue, we saw IDCs, 3 or 4, in a span of 10 months, which have been sent a trigger to us to get it reevaluated again. Is it truly so? But they were. So maybe it's histology, seeing them better.
And can the biopsy, sir?
What we are saying is intraductal carcinomas are in a patient who have a TURP done and biopsy coming in a transitional zone, number one.
Okay.
I was talking to the pathologist and she said to me that you will have to equate this like ER/PR plus HER2. That will be going to be the thing, because again, if you consider prostate and breast, endocrine dependent, sinus carcinoma, intraductal carcinoma. So we'll have to look into this intraductal carcinomas as like a breast cancer, where you look at ER/PR and as well as BRCA and HER2. So that's the news which came to me.
Can the biopsy and MRI confidently pick up these unconventional histologies? Dr. Kausik, sir.
I mean, honestly, no. I have but very less experience in the uncommon histologies, but I tend to agree with your point made that the recent crop up of more of these uncommon histologies may be a factor of the pathologists becoming more sophisticated in this.
More
but I don't know how it impact the treatment. I don't know that.
So Dr. Pankaj, sir, can you say the correlation between the biopsy findings and the RP findings on detecting these UH? Okay. Then they
Just to add one more point regarding cribriform. We used to believe that this is a totally like it cannot be scored as a Gleason score. But Dr. Borges always told me that this should be taken as a Gleason 5, grade group 5.
No.
This was 10 years ago. Cribriform should be taken as a GG5.
Now they're taking as 4.
Now, of course, now.
Sir. So the paper that was presented had a 16% incidence of UH, and there is data that the incidence of IDC keeps on increasing. By 56% in patients who present with a metastatic disease. Regarding the detection of unconventional histology on MRI and biopsy, MRI picks up unconventional histology in around 80 to 100% of the patients. The sensitivity is 80 to 100%. However, it can be biopsied in only 50% of these patients. And of note here is that the men in one of the studies of the cohort of men who were fit for active surveillance, the biopsy could be picked up in only 34% of the patients. And probably that is the reason why we discussed that the MRI having a high risk aggressive disease on an MRI is considered to be a slightly weaker contraindication to active surveillance by the detective study. So MRI picks up the UH. However, it may not be able to always be able to or sample it on the biopsies. So would you offer active surveillance in patients if the biopsy is probably no? Probably no. The next abstract discussed the functional outcomes after localized cancer prostate treatment, and it showed that the patients who undergo RP had worse urinary functions, patients who undergo RT had worse bowel functions, and considering the long-term oncological outcomes to be the same, it all comes out to patient choosing his own complications. So my question, Vivek sir, my question to Dr. Pankaj sir. So what are the common functional problems post RP that need to be discussed with the patient?
So clearly, is a discussion we have to be.
Any numbers and figures that?
So the
So in your experience, a patient who's best suited for RP as compared to RT in your
no question
is preferably better off.
So if poor really a bad ones should automatically not go not go. I think that's
I have a question.
they are the one
Okay, if it is a TG5 high PC, high risk, so what do? You operate and then select?
so they are
No, I would not ask why. I would say do a term, wait for 3 to 6 months, and then do just radical.
I will completely agree with you. I will completely agree. The patients who would go for radiation, that should be avoided as far as possible. Having said that, in the community, we do see a lot of patients who have undergone TERT under the care of a non-informed urologist. And we all end up with those patients for radiation, and they have very poor functional outcome. as far as possible, if you can, we give adjuvant hormone, keep the patient on catheter for a while, bring it down, bring down the nuts, and then go ahead. That should be the way.
Okay. Sir.
It's okay.
It's a,
That means you're giving capital to be.
uh,
So here he's talking, avoiding surgery still, neoadjuvant hormone is what you're consented. If the thing that becomes fine, go ahead with our patient. But it's not a necessary thing which
sir,
I'd say.
we'll move to the next question. So, we're, to Rajiv, sir. Sir, what are the risk factors for stress incontinence post RP in your experience? Preoperatively, if we can.
The one thing, of course, there are two aspects in prostate. One is the vertical extent and horizontal extent. Horizontal, there's no problem, lateral margins. Vertical, apical margin. If there is a disease at the apex and you have to go beyond what is required for the oncological safety, that's going to work.
That's a problem.
Whereas the bladder neck is not a big problem.
Okay.
Even if it's close to bladder neck, if you have to exercise more bladder neck, no problem. But the apex is the one which is very important, anatomical.
Rajiv, sir, you want to add anything?
Yeah, so when we are deciding about a radical prostatectomy, one of the foremost thing in our mind is that we don't want to make him incontinent. Of course, it happens sometimes, but we don't want it. So clinically, MRI helps a lot in deciding. As sir said, that if the disease is at the apex, it is the apical area is not very well defined, stay away from these. If it's at the base, even if it's involving the lower half of the SV, you can still go ahead. And how, when we look at a patient, if the patient is short-statured, stocky, explain to them. I mean, in nicer language, but if the patient is very obese, also short height, these patients are more likely to have incontinence or maybe delayed continence of the mark like this. And also, if after TURP, if the patient had stress urinary incontinence, stay away from them. If they are absolutely fine from day one, look at the MRI after 3 months and then decide. Always make sure that they do not have a stricture because it happens.
So just last question to Dr. Kausik and Dr. Vivek here and Dr. Rajpal Singh, sir. So what are the patients best suited for radiotherapy as compared to surgery?
From the context of toxicity?
From the concept of, yes, functional outcomes.
Well, see, the main thing here is that the bowel toxicities are more with radiation. And this graph is consistent with all previously published articles who have tried to answer this question. Now, one thing is that whether it's including patients who have undergone pelvic radiation or not is not very clear from this. If the patient has, today we avoid pelvic radiation barring one trial which has shown the benefit. In that case, that the bowel toxicities may not be as bad as it is showing here. That said, it is important to understand that after 10 years, outcomes and toxicities are all same.
Okay.
So there is honestly speaking no great choice. I will leave the decision with the patient. If it's a young patient and for him the sexual function is really important, I will push for surgery, all things being equal. But if the patient is relatively elder, then I will possibly not consider, sexual function as one of the factors and take it up.
Yeah, I agree with him, but I would not, again, as the surgeons would not say that don't mess with people who have a lot of LUTS problems. I would say that they will come back to us, and when they go back to the surgeon, they say, "Oh, why did you do radiation? You should not have done it." Definitely, I will wait for the LUTS to come down. Antagonist helps us a lot. Antagonist giving about 6 months definitely helps all these LUTS problems to reduce than agonist. If there is definitive data by the British Columbian colleagues. And
Rajpal, sir.
One more thing. If the patient has hemorrhoids, if the patient has a lot of constipation problem, again, I would say I would add more of brachytherapy dose than external beam. So external beam, I would be very cautious.
Sir, last comment.
And moreover, in the era of IGRT, IMRT, these bowel toxicities or all other toxicities regarding organ at risk are very less. So these are the trials which are being done prior to that. So nowadays we are doing bladder protocol or we're doing urethral sparing IMRTs also. So the toxicities which are being shown in these trials are from previous era, not from this era. The technique has improved over this period.
So that will we'll like to conclude the session. Thank you, panelists, for the.
Good afternoon, everyone.